The webinar is started.
Okay.
Ons is op die lig.
Lijkt nog niet of daar onder the disaster medicine lead for Right to Care, and I'm supported by quite a few colleagues from the infection diseases environment, infection control environment, governmental institutions, different NGOs, quite a few managers and from emergency departments on the group. Really interesting audience that we have this afternoon. It is our privilege to present to you this afternoon a presentation by Miriam Molenaar. Miriam is presenting this out of Malawi. And Miriam indicated to us that she's, first of all, Dutch, which I think we can all deduct from the surname, but she's staying in the US currently and is working in Malawi as the medical coordinator for emergency response for Médecins Sans Frontières in Malawi. So in this context, Miriam is organizing the current response in a certain district or districts of Malawi, and she will be talking to us about their situation and how did they manage this challenging situation. Now, I think for a lot of us in South Africa, we may not be totally aware of the extent of the cholera outbreak in Malawi currently. This outbreak started way back in November of 2022. It was declared a public health emergency already by the World Health Organization on the 5th of December 2022. And currently, up to now, Malawi have seen 47,000 cases of cholera. I think we just need to take note of that number, of which approximately 1,500 have died. Now, very importantly is that this may be underreporting, and there may be even higher figures than that. 47,000 patients with cholera, 1,500 that have died, and the World Health Organization has given a high-risk category to the total Malawi for cholera. Just on the call a little bit earlier today, there were 3,200 new cases of cholera just this week, with 77 cases. 77 deaths. Miriam is going to give us an overview on the practical management of cholera and the successes they have achieved in Malawi. She will highlight to us the challenges that the teams are facing, very specifically in this outbreak and in a resource-restricted environment. And I think for a lot of us in South Africa and from the neighboring countries that are joining us, we may not totally understand how restricted the resources are in Malawi that these people need to manage cholera with. She will also share with us the practical solutions that they found. And some of these solutions may be quite surprising to us, which are used to sewage systems and a functional hospital environment. She would also explain to you the challenges that they face on a daily basis, the solutions they find, and how they address these issues. This presentation by Miriam will be recorded and will be available to you if you want the recording for use in future engagement. So we've got 112 attendees, Miriam. We're looking forward to listen to you, and I hand over to you. Miriam?
Thank you very much, Theo. Thank you for having me, and good evening, everybody. So the MSF Médecins Sans Frontières cholera response in Malawi. Our response started in Kochi, which is a small town in Mangochi district, on November the 3rd of 22. Actually, the first cases of cholera were already reported in March of 22. And our regular cell of MSF, who has a cancer project and an HIV project in the country, had already responded to a much smaller outbreak in May. In September of 22, cases started to go up and up much more significantly, and the regular cell started a project in Koche in early November. As the size of the outbreak and the needs for intervention became rather large quite quickly, the response was taken over by our emergency cell in the middle of December. I was actually the first one on the ground from the E cell in the beginning of December. Next slide, please. As I was alerted to the fact that many of you may not know the ways of transmission of cholera and what it is, I will just briefly tell you about this. So cholera is an acute diarrheal infection caused by the bacterium Vibrio cholera. The incubation time to develop the disease ranges from a few hours to 5 days. Cholera, actually, 75 of people who come in contact with the Vibrio will not be infected. About a fourth of people will get infected and will show signs and symptoms. Of the people infected, most of them only show mild symptoms. This is about 18%. 5% of cases show moderate symptoms, and 2% show severe symptoms. The disease, if untreated, will lead to severe dehydration and possibly death. If the disease is untreated, there is about 50% of mortality for those who are severely dehydrated. The disease is due to a lack of clean water and sanitation, and therefore is found mostly in camps, such as refugee camps, in flood zones, in slums, in unplanned settlements, and in many villages here in Malawi around Lake Malawi, where the toilets and running water are lacking. So it is related to inequality and poor access to health. The transmission, imagine a person who has cholera, they will have diarrhea. If you don't have a toilet, this may happen close to a water source in the field. People will not have appropriate means to wash their hands, so they may infect, it may be the infection may be on their hands. Flies will also spread it. And in this way, it will get into the food system and will get to the new host, the new person who will have the disease. Our natural flora in our stomach, our gastric acid, destroys the Vibrios in part and gives us a certain level of protection. The Vibrio multiplies in the small intestines, crosses several layers of the mucus, and will colonize. Vibrio, the bacteria, releases a toxin that will draw out water and electrolytes, which causes a large amount of this in the intestines, which leads to an extremely profuse diarrhea. This is a diarrhea in which people will lose 5 to 10 liters of fluids in 1 to 2 days. This is why it is so lethal if untreated, because at this level of dehydration, which is up to about 10% of 50 to 60 kilogram person, you can imagine that people will come in coma. I will return, so this is just a little bit of the background of cholera. I am Dutch. Even in areas in the Netherlands, Vibrio has been found. I have never heard of a case of cholera in my country because everybody has running water and toilets. Koche, Mangochi district, a small town. Our response started in one of the CHAMP hospitals in Koche. by the regular cell. As I just said, the E-cell came in the middle of December. Initially, we worked with staff from both the Chomp Hospital and people that work for the Ministry of Health in the Mongochi District Hospital, which is about 20 kilometers away from Koche. When we arrived there, there were many, many people laying under the trees and the situation was desperate. Next slide, please. When we started, the cumulative number of cases was 495, with 8 deaths in the facility. You can see on this graph where we came in November, there were about 74 patients when we arrived. Later in November, the cases actually rose and went up over 100 cases in this area. The peak was reached and then it slowly trickled back down in December. Next slide, please. This is the situation we found. Multiple people. You can see that with no provisions, lines hanging from the trees. The staff, the Koche staff, was honestly trying to do what they could, but they didn't have any means to treat this appropriately. There were inadequate numbers of untrained yet very hardworking staff, inadequate supplies, and as you can see, no appropriate setup. Next slide, please. We set up a CTC, so we call this a cholera treatment center. There are also smaller units that are called cholera treatment units. It's just a matter of how many beds are provided. Usually under 20 is called a unit and a center is above this. We set up this CTC and throughout our intervention, from November the 3rd through December the 23rd, the number of beds was adjusted to the needs. Similar with the number of staff required for appropriate case management. As a general rule, CTCs are managed by a team of COs or medical doctors, but these are very hard to find in Malawi. So we used COs, nurses, health surveillance agents. There are many of those people in Malawi and they fill a multitude of roles. They often help the Ministry of Health in vaccination campaigns. They are health promoters. They also are active in distribution of soaps or chlorine when it's needed. They prepare the bodies of the deceased. So we worked closely with these people. In a cholera treatment center, you also need a lot of hygienists as well as crowd controllers. And of course, supportive staff, managers, logistics people, and whatson. We assisted the Mongochi Ministry of Health in December with a targeted vaccination campaign in mid-December. There were 185,000 vaccines left. As you can see, not all of these were used. 79% were used. And the target population was the population around the lakes and the waterways, the hotspots, so to speak, of this cholera outbreak at the time in Mongochi. It is important to know that normally to protect us from getting cholera, one gets one dose, and then the next dose of cholera vaccine is given within 4 weeks. Unfortunately, globally, there is a shortage, a severe shortage of oral cholera vaccines. So Malawi had only a very limited number of vaccines available to them. In mid-December, we realized that the numbers in Koche decreased, while at the same time, 20 kilometers away from us, the cases increased in the district hospital. One of the things that was significant was that when we went there to assess the situation, there was one tent, one CTC tent in the back of the hospital, and in the front, in the middle of where everybody came into this hospital, was another tent set up with very poor hygiene. Cholera requires a very stringent infection control protocol, and a lot of hygiene measures need to put in place. Otherwise, it spreads like wildfire. So in this hospital, hardly anything was available. Next slide, please. So here you see two pictures of our Koche intervention. Soon after my arrival, also the rain started to arrive, and which is also very dangerous because the water then starts to flow and will spread the disease even more, will spread the bacteria even more. And you see one of our assistants carrying 2 cholera beds. A cholera bed, as a general rule, has a hole in the middle so that people who are laying down, when they have an episode of diarrhea, it goes into the bucket underneath the bed. We make these beds here in Malawi, as when we arrived, there was very much a shortage of these beds. And if you make metal beds, it would take up to 6 weeks. So we set up a workshop with our carpenters who continue to make 30 beds a day. Next slide, please. We started the intervention in the district hospital right before Christmas. As in Koche, the aim of the intervention was to decrease mortality, improve patient case management, and build capacity of MOH staff. Our goal is never to just come in and take over. Our goal is to build capacity and decrease mortality. We maintain the same principles for intervention later on in Blantyre as well as in Lilongwe. In the beginning of the outbreak of our intervention in November, medications and supplies were very problematic. MOH, however, started supplying drugs and consumables for the cholera intervention in the middle of December. We were able to assist with filling gaps. This was mostly for certain antibiotics and zinc for children. Zinc is a medication that will prevent children from getting diarrhea again shortly after they have already had diarrhea. And we also train people on how to order appropriately. It is hard for Malawians to think ahead. Usually people wait till they have no more medications before they order. We realized that the outbreak was spreading, and it seemed to reach a peak with cases rising in many areas. Now, at the time in December, at the end of December, 48 out of the 49 districts in Malawi were affected by cholera. And we saw high numbers in Blantyre coming up. Next slide, please. So over New Year's, we set up 2 more cholera treatment centers in Limbe and Maketa. These were health centers in Blantyre. What we realized was the difference in terrain and the difference in affected population. Mangochi is a very rural district. There is space between people. Blantyre is a city with about 20 health centers spread out. So we set up these CTCs in the health centers that were the most affected at the time, 2 of them, Limbe and Makete. A week and a half later, we set up 2 more CTCs, both in Bangwe and Gateway. This is all still in the same city. Logistics and Watson work was done on all of our sites, because when you set up a cholera treatment center, you need a soak pit to throw out the buckets with diarrhea as well as vomit. You need separate toilets for staff and patients. You need showers for patients. You need an area where caregivers can wash the laundry and so forth. You need often water supply, as cholera requires a large amount of water per patient for hygiene, as well as the fact that people need to receive oral rehydration salts. At the same time, we received a request from the Ministry of Health and the Blantyre prison manager on January the 5th. Blantyre prison houses about 2,500 prisoners, and only around 1,600 of these had received the oral cholera vaccine. In a prison, obviously, people live on top of each other, so the risk for a significant outbreak was high. When they called us, they had 6 cases, 2 of them had passed away, so very high mortality. We came in on Friday to discuss the situation. On Saturday, our health promotion and medical team came in and we sensitized the population of the prison. And on Sunday, we went in with assistance from the Ministry of Health. A lot of HSAs joined us, as well as their health promotion team, and 900 prisoners received a dose of the vaccine. All people received soap, and we set up hand washing points. All of this was lacking when we came into the prison. Since then, the prison has not reported any cases. We were able to help them out, giving them some cholera beds, but also we realized they did not need our help anymore because they have not seen any cases since then. Next slide, please. You can see a part of the sensitization on the left. This is Labana, our health promoter supervisor. We started in a small room. You cannot see it, but there were 300 people packed in there. Luckily, after this, the rain stopped, so we immediately went to the large field that they have to sensitize the remaining 2,200, mostly gentlemen, a large crowd. In the right picture, you can see that we are distributing soap after people get the oral vaccination. We were lucky in that sense that, of course, cholera vaccine does not require an injection, so it's easily given. It goes quickly. Next slide, please. Health promotion, sensitization, and raising awareness is a major part of any cholera intervention and was a part of our strategy since the beginning. We have CATI, which is called case-targeted intervention, and we have utilized this in a watered-down version, so to speak, since the outbreak. CATI is normally an approach in which you improve water provision, sanitation, and hygiene. You vaccinate people, and you even at times give them prophylactic antibiotics. The idea is that you follow trends and you would go to a hotspot. Let's say in a village you have 5 affected people. You make a large circle around these people, let's say 100 households, and these are targeted for your intervention. It is the same idea as vaccination, where you want to get to vaccinate your herd population so that everybody surrounding the case has a level of immunity and the disease doesn't continue to jump from one to the other person. Unfortunately, we at the time had limited ability to provide wash activities. There was also the lack of the vaccination supply in the country. And so we did it with providing people with buckets, with water guard, and at times chlorine. This is a way to provide appropriate water. A cup, the hood of your bottle of water guard, you put it in a bottle and you have 20 liters of safe drinking water. So this was dispensed to the population with a lot of education. When we were in Blantyre, it really became more and more clear that each district requires a different intervention. As I told you, here we set up these 4 sites. And when the disease spread within Blantyre, we realized that we did not have a big enough team to set up CTCs in 20 healthcare centers. So we had to come up with a different strategy. We also realized that whereas in Mongochi, children, particularly young children, were most affected by the disease, up to 50%. This is because children play in water when it rains. They play in the lake. So they were affected more than here in Blantyre, where I currently am, where most of the patients is adults. We also realized that now Lilongwe was highly affected, and as other actors were not yet encountered on the ground, we went to Lilongwe to follow the rise of cases there, particularly in Bwaila Hospital. Next slide, please. I put this slide in to show you that we are working with a geographical information system. This is not a static system. We have someone who is specialized in this, a GIS agent, and he plots all the data that we receive on these maps. We have this map starting back in January of 2022, and as you scroll along, you can see the hotspots getting bigger, which is in yellow, and then getting smaller again. So in inputting all of this information in this system, we could follow the trends, and it also showed us where the highest needs were as much in Blantyre as well as in Lilongwe. Next slide, please. It's a way to show you how much, what the importance is of a good data collection system when you have infectious disease. Food for patients has been a part of our activities in Mongochi district since the start. When we came to Blantyre, we didn't initiate it right away because our sites were smaller and people seemed to manage. Currently, however, we have changed our strategy. As I told you, we realized that we could not go to 20 centers and set up CTCs. So we have enlarged 2 of our centers to 50 and 35 bed capacities. And we now provide food in these centers as well, Gateway and Limbe. Food is an extremely important component of the treatment. When I told you about the cause of cholera, I think it is clear that it mostly hits the poorer population. These people often already have a compromised nutritional status prior to contracting cholera. So where providing food improves the overall status of the patient, lack of proper meals can prolong any hospital stay and worsen the overall condition of the patient. It also obviously complicates then your treatment because your site will fill up. In addition, when food is not provided, the caregiver, and we allow 1 caregiver per patient, this is the rule in cholera. You allow your patient to come in with 1 caregiver. When you don't provide food, the caregiver, of course, will go out and come back in at the site multiple times a day, increasing the spread of the disease and putting other patients at risk. Next slide, please. This is a lineup of the women. We gave everybody tickets and caregivers, often women, but we also saw a lot of fathers coming with their children. People got 3 meals a day, and we're happy with this. Next slide, please. When we arrived to Lilongwe, so now we are talking early January, it was the 11th, I was there with the coordinator. It was just the two of us. Bwaila Hospital had already opened a cholera treatment center. The site was in a very bad condition. We found a large number of patients laying on old pallets of an old COVID tent. No beds, no buckets. IPC was non-existent, and the medical staff, although motivated, reported being entirely overwhelmed. It was obvious. We realized that in such conditions, you cannot start with being a team of 2 people only. So we made plans to return to Bwaila with an entire team, including medical wash, logistics, and supplies. And we did so a week later on the 18th. In that same week, we also realized that there was another outbreak on the lake. Prior to any intervention, we always make agreements with MOH, with the district health officer, with the district medical officer, the district environmental health officer. Then there are district nurse officers, district health promotion officers, and so on. We discuss our plans for intervention with all of these people so that they agree to allow us to come in to help. Also, prior to coming in and simultaneously as we come in, we already start the sensitization in the communities. This is crucial. In Bwaila Hospital in particular, we had excellent collaboration with the entire group of people, the DHO, DMO, DHO, and despite challenges, we continue to move forward there together every day. Next slide, please. Here you can see the tent that we set up in St. Martin's. So when we did this assessment in Bwaila, I got a call and there was another outbreak in a Chom hospital in St. Martin's. This is a small town right on Lake Malawi, and this tent that the picture you're looking at is probably 100 meters away from the lake. Next slide, please. So the sharp increase made that people in this hospital were laying around on the floor outside under the trees again when we arrived. We set up an initial number of beds of 30 that we later increased to 53 beds as people hear, of course, what's happening somewhere, and people affected by cholera from other catchments area chose to come to the MSF site. We provided food from the start. We brought in our own team again, and this time to work again with the St. Martin's staff to increase their capacity. We also saw an increase of cases again in Mongochi District Hospital. And for a while, we had an average census of 90 patients daily in Mongochi District Hospital and 40 in St. Martin's. Since then, the census has gone down tremendously. Since the third week of January, there has been a steady decline in cases, actually in all of our sites, in Mongochi, in St. Martin's, in Blantyre, and now also in Lilongwe. This, of course, is very hopeful, but there are still smaller health centers reporting increased cases. And we are now negotiating with the Ministry of Health to set up what is called oral rehydration points. The idea is a bit similar. We are also doing this in Blantyre now, that due to a lack of staff and supplies, ability to set up these tents everywhere, this is quite frankly impossible. You set up these smaller rehydration points spread out in a city or in a district so that people can go there. They start to be rehydrated either orally or with an IV, and then you set up a referral system with ambulances to take patients to your CTC. So this is what we are currently doing in Mongochi district to bring them to the hospital, and here in Blantyre to bring people from various places around the city to the two centers that we have concentrated on. In Bouila, we have seen major improvements. We have done a lot of wash, so water and sanitation. We have cleaned up the cholera tent, the big tent. It was one of those grub tents. It has 8 compartments, and the floor was the old pallet floor that was used for COVID. So thousands of needles and glass vials used that one uses for antibiotics were laying in between these pallets. So that's what we were looking at. This also meant that we could not clean the tent appropriately, and you can imagine that people laying on the floor with bouts of diarrhea and some with vomiting, that doesn't help you in providing care. So all of this was removed, and all of our tents have plastic flooring so that it gets cleaned throughout the day. Next slide, please. Here are some numbers. In Blantyre, the average case fatality rate was 1.1%. So think about 100 people, 1 death. MOH numbers for Blantyre were 2.3. In Lilongwe, the average for MSF was 3.5. This is unacceptable to us. And in the district, the number was at 5.9. The average in Mongochi was 2%, and in the district, 1%. You have to realize that these numbers are based on MSF and Ministry of Health data. We know that there is underreporting. We see this on our sites. When I arrived in Limbe, and that's why I become emotional each time as a provider. When I arrived in Limbe, I found 5 people dead on the floor. These cases were unfortunately not reported. This happened for a few days in a row as no one was there to be found over the New Year's holiday. Case fatality in our Blantyre CTC has improved. It is now 0.7%. When you see the change from week 6 to 7, you see it has gone up a bit. This is merely a reflection of a decreased caseload. So if you have 100 people that you treat in a week and you lose 1, your percentage, of course, is lower. Now that we have fewer people coming and fewer people on the site, if you have 1 death, this will raise your case fatality rate. In Lilongwe, we are very pleased since staff has been trained, we brought in more and more staff. The case fatality rate is now down to 1.6%, and in Mongochi to 0.7. Training people for cholera is incredibly important, and that is the crux of intervention of the nurses and of your COs. It's an easy treatment, cholera. Next slide, please. You can see on the left what we found, and this is already with MSF intervention in the tent. And on the right, you can see the tent, how it was after our cleaning up. Next slide. We did an assessment of the Dzaleka refugee camp. As I said before, camps, settlements that are unplanned or slums are particularly affected. And the refugee camp, the biggest refugee camp in Malawi, is about 30 kilometers north of Lilongwe. It has a population of about 56,000 refugees, but we consider the surrounding villages that attach to this as one. So we were asked to come and perform an assessment and also to give them a report with recommendation on how to prepare for cholera. So we did this. The camp had only an 18.75 vaccination coverage. So you need at least 70 to see any results of this. So we knew it had the potential to be a disaster. Since we have given these recommendations, we have been approached by the UN, by WHO, and by UNICEF and other actors that have come in to Malawi since a few weeks ago. And this week we are actually training the staff that has now been allocated to work in the Dzaleka refugee camp. So this staff is coming to Bwaila, and we are training them on cholera treatment, on case management. So as an ECEL emergency cholera response team, we have been very happy with the arrival of other actors on the ground to collaborate with. WHO, Save the Children, UNICEF, and many others like yourself. We have reached now the point in Lilongwe where we can train medical providers of other organizations on proper case managements. Things have been set up to train staff, as I told you, for Dzaleka camp. In cholera, as I told you in the beginning, 2% will get severely ill. The people that are affected, that are moderately ill, are at increased risk, because when you are moderately affected in cholera, you can quickly become severely ill. There are groups of people that are particularly at risk for this. They are people with underlying conditions, HIV or TB, as often when you get sick with cholera, you of course don't take your medications anymore, and this worsens your condition. Children sometimes have co-infections, malaria or malnutrition or pneumonias. So you have to be aware of this, jump in and treat these things effectively. Pregnant women are not at a higher risk to be affected by cholera, but they are at a high risk for loss of the fetus, because when you are severely dehydrated, imagine that you have now lost 8 liters of fluids. That means your blood pressure will go below 90 beats per minute on your systolic blood pressure. And that means there is not enough pressure to provide blood to the fetus. So we have set up in our tents. We try on our sites to divide tents to have a tent for men, women, and children, and then a special area for pregnant women because they need more attention. Cholera needs to be regarded much like COVID and Ebola, where you do not want for these people to go to other parts of the hospital because then you would spread the disease. So we have set up areas in the cholera tent for the pregnant women, and we have had successful births with healthy children. We have even had C-sections in the cholera tent. We do not do this ourselves. Again, we work closely with the staff of the Ministry of Health facility. For instance, in Mangochi District Hospital in Koche, as they did not have ability in Koche Hospital to do C-sections, we transferred pregnant women to Mangochi. We do the same here in Blantyre. In Lilongwe and in Mangochi District Hospital, we work together with people from the maternity. We alert them when we have pregnant women in the tent and when we believe that their condition worsens or might worsen, so that rapid intervention can be done to at least save the life of the women and, when possible, also of the newborn. Next slide, please. This is a picture of the old COVID site in Dzaleka camp. It already had a cement floor. All they have to do here is clean the place up, place cholera beds, refurbish their waste management, their soak pit, and get the staff. Next slide, please. As you can hear when I talk, cholera can be one of the saddest diseases, as no one should die of cholera in 2023. Yet at the same time, it's one of the most rewarding diseases, as people arriving in shock may smile at you just 30 minutes later after a few liters of Ringer's lactate. To date, we have been able to treat 10,380 patients with cholera. I hope this helps you to help organizations that might prepare for cholera in South Africa if there were to be an outbreak. Here we seem to be on the good side of the epidemic curve. I thank you for your attention, and I would like to show you my favorite slide. Next, please. He went home successfully treated. Thank you.
Thank you, Miriam. Thank you, Miriam. That was a very sobering presentation. And MSF team has clearly saved many, many lives and taught many, many lessons. I think South Africa is definitely at risk. I think the whole region is at risk. There are major problems with water supplies, ablution facilities. There is a cyclone, there are floods, and there are major disruptions to safe water. And I think we are not prepared. In 2008, 2009, I was part of the group that responded to the cholera outbreak that came over from Zimbabwe. And the problem with cholera is you have one case on a Friday, and if it's a water supply that's contaminated, and it usually is, you have 100 the next day, 1,000 the next day, and you have a major, major crisis on your hands. So I think we need to improve our surveillance. We do have laboratory support. Safe water is obviously the key intervention, but it's easier said than done. There is a global shortage of vaccine, and it's not going to be quickly solved. But the treatment, if given timelessly, either oral rehydration fluid or intravenous fluid by trained staff who've got adequate resources, is, as you say, hugely rewarding. And as experience improves over a few days and with some quick training, as I think MSF have really clearly demonstrated, Ringer's lactate given correctly with frequent checking of patients' condition. It's not like ordinary diarrhea where you can come back 6 or 8 hours later or the next day and reassess patients. It's that continual assessment, but really community awareness, provision of ORS and hygiene information, even given limited resources, I think it's clearly critical. So thank you for what you've done. Thank you to MSF for a huge contribution, not only with cholera, but all other diseases. So I'm going to take some questions now. There's quite a lot of comments in the chat. So what was the profile of the deceased patients? Age, other comorbidities? Anything you'd like to raise? I think you've given us some of the risks.
So comorbidities that we have seen are often the HIV. Malawi is also highly affected by HIV. And comorbidities for children are often malaria. Malnutrition I have seen more in Lilongwe, because Lilongwe has a large slum area. Actually, all around the south of the CTC is a large area with slums. And that's why we see more malnutrition in that area as a comorbidity. We are now, of course, having more and more rain, so I suspect that we might see more malaria cases as comorbidity as well. Otherwise, when we find we have had a few pneumonias, one other thing that needs to be closely supervised is that, for instance, some caregivers want to push food too rapidly when the patient is not yet able to take in food, causing aspiration pneumonia. We've had a few cases of this, and obviously that means that you need to improve again your health promotion and awareness within your cholera treatment center, but it is definitely a risk. And you are absolutely right. Cholera is not you stabilize the patient in your triage center and you move them to the tent, because imagine someone who comes in who is an adult, who is now severely hydrated, meaning they have lost over 10% of their weight, so 10 liters. The initial stabilization will use maybe 4 liters of Ringer's lactate, but that means that this person is still lacking 6 liters. So if you bring him to the tent and you forget to follow up initially every 15 and later every 30 minutes, and this person still has diarrhea, obviously, because they are still affected, then they can quickly get sicker again, and this is how you could lose patients. So it is crucial to stay on top of these people, to walk through your tents time and time again, to push the oral intake as fast as possible, because this is where you get your electrolyte replenishments, the things you have lost with this profuse diarrhea. Ringer's lactate doesn't give you enough, it just gives volume. It's in the ORS that you have your electrolytes. And this is also why food when the person is able to eat again is so important because they will get the electrolytes.
Thanks very much. So I think just to follow on that, some practical experience of how you've organized patient flow and staff flow in a CTC. I remember we used to put labels on the patients, a red, a green, an orange, and then they used to move through severe, not so severe. Just some ideas of how patient flow and things are managed.
So the way we have done it is every site has a large triage site. So this is where the person is assessed. Next to that is a place for observation. Those people who are only mildly affected and who are still drinking well, they go into observation. They do not get admitted. The moderate and severe cases are admitted. We never do TENS based on severity. We organize the TENS, as I said, as much as possible in men, women, children, and then pregnant women. And that is because of the fact that a person's status changes so quickly. You can be severe, but you will be moderately affected in only maybe a half an hour. And then it's a matter of that close follow-up to make sure that you do not become severe again. So our flow is to go from triage either to observation or to admission, and then people stay in the same area until they are free or they have recovered from cholera, meaning they have not had an episode of diarrhea for 12 hours. They are eating and drinking adequately. And that's when they go to a discharge area. We do discharges twice a day, after morning rounds and after evening rounds. Then these people are grouped together with their caregivers, and the health promoter then does another session prior to discharge. And people also receive a discharge kit, which is again a bucket, water guard to provide them with safe water, blocks of soap, and some ORS before they go home.
Have you had any readmissions after you've discharged? Just as a point of interest.
Yes, so it's a very good question. So for our sites, when we had readmissions is when we just come in. What happened in many of the MOH sites is that when, I will give you the example of Maketa, they had lots of readmissions prior to our intervention because they were so overwhelmed that they discharged people before they were cured. And like I said, that means people will go home not being fully hydrated, still having significant diarrhea, and so they were readmitted. They were discharged too soon. The other thing that we have seen, and with appropriate intervention and a lot of health promotion and good hygiene, this is how you prevent this. There were sites where you would have a mother and a child, the mother being the caregiver, and then 2 days later, the mother comes as a patient, or the sister, or the father, or the neighbor. The caregiver can become the patient if there is no appropriate hygiene and education of the caregiver. So these things are very important.
Thanks very much. To mention that in the outbreak that we had here, we found that there were barrels kept in households where people used to put what was thought to be safe water. But the barrel of water got used for everything, for drinking, yes, hand washing after toilet. And they found some quite simple systems to I think it was a Coca-Cola bottle, to dip that in, get some water from the safe water supply and use that for hand washing, so that there wasn't this mixing.
Yes.
It was a simple solution that didn't cost very much. Yeah.
Yes. Yeah. And cholera, you know, it is incredible. I mean, to me, it's always difficult when you do a presentation and then in my mind, I see the people we lost. But it is also incredible how people are cured in a few days. The average length of stay when it is well done is around 2 days.
Okay,
so it's incredible.
Yeah, it's the golden hours initially. And when we
Yes.
looked at our deaths, it was early in the outbreak where the cases were not recognized as cholera and they were managed as ordinary gastro with just
Yes.
wrong fluids and no reassessments. Even without a laboratory, you can manage these patients very well. But it's that attention to detail in those first 6 to 12 hours and lots of fluid.
Yeah.
So did you use any antibiotics in the severe cases? Do you think there's a role?
I do think there is a role. So MSF protocol is based mostly on doxycycline. Large studies have not shown that doxycycline has an effect on the fetus or in children over age, but we have adjusted here to the MOH protocol. So we give antibiotic to people who are moderately and severely dehydrated, not to the mild cases, only to the moderate and the severe ones. And they get a one-time dose when it is doxycycline. When you use erythromycin, it's given for 3 days. And this is the Malawi protocol. So children and adults, every case that is moderate or severe gets antibiotics. There are times where, where one could think about prophylactic antibiotics, but we have not done that here because you would only do this if there is not a risk for reinfection. And unfortunately, since our people are coming from these poor areas and slums where they do not have proper sanitation, we do not give prophylactic antibiotics because, they would be in your system, but then 6 days later, a week later, you may still get cholera because you are still around it. So it is all health promotion, awareness, education.
Yeah. So just to comment about diagnostics, it's not routine to send stool to laboratories to confirm cholera once you have an outbreak and an established outbreak in an area. You certainly don't wait for the results. And I would imagine for most areas, laboratories are limited. It really is a clinical diagnosis of acute watery diarrhea, especially with dehydration, especially affecting adults. That is enough to think of cholera and manage the patient accordingly. I think it's just important to mention that. So
Absolutely.
just to move to a couple of other things. What about the vaccine? What are your feelings about the role of vaccine and how to identify risk populations? Clearly you've done quite a lot of that, given that there's a major shortage and it's not about to improve tomorrow. And then we can talk a little bit about the vaccine and how long you expect it to work, and there are some limitations. It's not the perfect vaccine.
No, and so the vaccine has, if only one dose is given, then the protection lasts from anywhere from 6 months to 2 years. So being realistic and with what I have seen, I would say it's more from 6 months to a year protection. If one can give 2 doses, the protection lasts for 2 to 5 years. So I would say 3 is a more realistic idea. I think that there is definitely a role for vaccination, but the vaccination should be organized from a central level by the Ministry of Health. And unfortunately, what I've seen here, for instance, in Blantyre, there were vaccinations left, and these were just handed out to health facilities. The people who come to get the vaccine do not need the vaccine because they come driving up, get out of their car, take an oral dose, and go home. Obviously, these people are not the people at risk for cholera. One needs to use these vaccines diligently and apply them after health promotion sessions in these areas where there is poor sanitation and hygiene, where people don't have access to clean water. For instance, around Lake Malawi, what we found when we did get our Watson team on the ground, a lot of the boreholes are not deep enough so that when people get water from the borehole, it tastes salty. So the population continues to get water from Lake Malawi and small streams to cook. And these populations need to get the vaccine. So there has been an order done to the fund, to the Global Fund for Vaccines by the Malawian government. And in my understanding, they now have asked for 5 million. We shall see what they will receive. If they do receive, then MSF will remain on the ground to assist in helping setting up the vaccination campaign.
So, I mean, given that there are many areas without safe water in most countries in Southern Africa, including many areas here, how would you prioritize? You know, it is limited and there's not lots to come from what I hear. And there are 30 outbreaks in the world of cholera. So, I mean, how do you prioritize that you're not too late and you reach the most vulnerable? Everyone's kind of living in a water problem area, safe water.
Yes, yeah. So unfortunately, there is no right answer to this because there are not enough vaccines, period. And the fact that we had the COVID outbreak, a lot of attention has gone to the COVID vaccine that has probably not done the cholera vaccine a lot of good because there is limited capacity to produce vaccines. And now we have this problem and we see this worldwide outbreak with a risk for this entire region, as you mentioned, of increased cases. So I would not be able to give you the right answer because there are so many people that lack appropriate hygiene and sanitation. But the one thing that we can do is health promotion. The one thing that we can do everywhere, even without a cholera vaccine, and I have seen the results of this. I have gone to several small fishing villages on the eastern side of Lake Malawi, close to the border with Mozambique, forgotten areas, marginalized populations, and by going in with health promotion and the medical team, people were sensitized and the outbreaks have gone down tremendously in these areas. So this is something that needs to be started ahead of time in any of the surrounding countries of Malawi, so that it gets started as soon as possible. Awareness, education on all levels. Radio, media should be involved so that people learn about cholera.
Yeah, I couldn't agree with you more. You know, I think we're putting a lot of hope on the vaccine, but before the vaccines were used for prevention or reducing the risk in cases of people exposed, the focus was on hygiene, awareness, oral rehydration in communities, and proper treatment if patients reach health facilities, understanding that management is very different to other cases of gastroenteritis. So I think South Africa really needs to improve preparedness. I think surveillance is critically important, to be on the lookout for cases and what our response would be, but also a lot of training of healthcare workers on how to manage cholera. It's not like other gastro. And if you do it properly, you can have those low mortality rates. So there's a lot of questions about what we should be doing. I think you've really highlighted. Just a couple of questions about disinfectants and what you've been using in the hospital. There's a lot of feces around. Cholera beds are one way. They're not easy to manage.
No. So we have different percentages of chlorine. We use, as it is difficult in such facilities to use soap, a chlorine solution of 0.5% is used to wash hands. Then we have a chlorine solution to prepare the body of the deceased, because that is also very important. Proper burial practices. The body needs to be prepared, placed in a body bag before it goes back to the community for burial. And there is a continuous disinfection of beds, buckets, floors, even people, even the caregivers, they get educated on how to do the laundry of the patient using a chlorine solution as well as soap, and then hanging it in the sun to dry. Buckets are continuously cleaned as well. So chlorine solutions in different percentage solutions are used for the disinfection.
Okay. And how do you protect the staff in the treatment centers? Everybody's used to wearing a mask now for COVID, but that's clearly not appropriate.
No, it's not appropriate.
Limited resources. So what are you doing?
So I'm so glad you bring this up, because everywhere that we arrived, I spent the first week explaining to people to not use and waste their precious resources, because who knows what will come here in 3 months. COVID, Ebola, other infectious disease. And I have seen people use, I call them the moon suit, the entire outfit for Ebola. It's not pleasant to wear, I can assure you, but people were even wearing that in some areas. And the only thing to do with cholera is scrubs, boots, gloves, and a thin plastic apron when an intervention is done, where you would expect splashing. If people do take a stool sample, then it is recommended maybe to wear a mask. If people have a cough themselves, of course, we still need to think about COVID. So at any time where our staff has a cough, they wear a mask. At any time where we have a patient that coughs, we do also have TB in this country, we give the patient a mask. But otherwise, boots, scrubs, gloves when doing when placing any IV or doing any other intervention with a patient, and then a thin plastic apron. We have not had many, actually I have had none of my staff being infected with cholera. I know that in MOH facilities there has been cross-contamination, but the first thing we do before anybody goes into the CTC as our staff is training of the staff. hand washing, wearing these boots. We do use a sprayer, a chlorine sprayer at the entrance of the site, even though this has not been scientifically proven. Research does not show a benefit of this, but it does have a benefit in the awareness of the people that come to the CTCs. So the fact that there is crowd control, of course, is very necessary to limit one patient, one caregiver, and then the disinfection of the soles, the shoes, adds to an awareness, even though we know that there is no proven benefit.
So thanks so much. Other questions? A number of people have raised the concern about staff and debriefing staff. You know, it's a very intense situation.
Yes.
It's quite traumatic. What is your experience in practice?
So we have the psychosocial unit. We have that for our expatriates. And we also have this for national staff. Because this is very sad when you work in this, particularly at the beginning of an intervention, and particularly also for the MOH staff. So we are helping the staff of the Ministry of Health. Also, we distribute the information to them that they might also need to get some help on a psychological level, because it's very hard to deal with.
Okay, and then do you follow up contacts? Is there somebody going to the household when you have a patient? Check if there are others, health promotion, is there a process?
So our process is, so our health promoters train the health surveillance agents, like I told you, the ones that are working in Malawi as health promoters, vaccinators, preparers of bodies, and so on. These people have also been trained by our staff, and they go out in the communities. So there are sessions in schools, there are sessions in churches, in mosques, with community leaders. In all of the areas affected, we have teams of health promoters going out. We have set up some special help for the pregnant women who may experience stillbirths or spontaneous abortions due to the cholera.
Okay, so I think there's a little bit of misunderstanding about the role of vaccine. The vaccine is given to communities at risk to prevent cholera or to reduce maybe the severity, but it's given in some advance of cholera in that community, and the advance is not very much in most cases. So I think that might clarify. COVID really raised many concerns around vaccine hesitancy and disinformation. Has this been a problem with uptake of vaccine? It's a question
Absolutely.
from Richard. Yeah.
Yes, absolutely. This is why we actually supported the MOH when they did the targeted vaccination campaign. The health promoters went into all these villages because otherwise people would have refused the vaccine. They all related the cholera vaccine to COVID. You know, there are all these myths going around, sterility for men, putting the disease in the body, trying to give them as a disease rather than helping them. But I have to say, proper raising of awareness and education is key. We have seen this, actually, I'll give this example in Area 25, which is also in Lilongwe, in the north of Lilongwe. The emergency team from the UK, from the United Kingdom, came in with support of WHO, several weeks after we started. So they also opened a CTC in that area. They now have 2, and this is very helpful in Lilongwe. But they worked with a large number of European doctors, people looking like myself, not like a national staff. And they had a security issue when there was a death on the first day, with a mob coming that wanted to destroy the CTC. The police came on the site, and this was really problematic. So once again, that shows that health promotion and awareness raising is crucial.
As a matter of clarity, are you vaccinating the staff and your own MSF staff?
We have vaccinated the staff that works in the CTCs, yes. Now, currently, that is no longer possible in Lilongwe because there are no more vaccines in Lilongwe. In Blantyre, we have been able to continue to do this.
Okay. I think I've posed most of the questions. I think the big thing is, and I'm going to give Hilda a chance to her hand is raised, is really prevention and preparation for future outbreaks. And, you know, despite recognizing that the root cause is, you know, the need for safe water and pollution facilities, you know, we continue to see this. I mean, that's clearly, yeah, the long-term answer, but
yes,
this is a big issue.
Yeah. We are glad that there are now many partners. There is a lot of talk here in Malawi now of organizations wanting to go in around the lake and improve the Watson situation. So I hope this materializes.
Hilda, do you want to raise your question? Hilda Maponya? I think you're unmuted. I think I've addressed. Okay, yeah, Hilda.
Thank you. No, it's just a mistake. Thank you.
Okay. I think we've addressed most of the questions. Any last questions you want to ask?
There's one more hand from Melly Hermine.
Yeah, please go ahead.
I think the hand dropped off.
Okay. I've tried to address, there were many questions in the Q&A, and I think many comments about MSF's work and the dedication that MSF always applies to all these outbreaks and where their need is. So thank you very much, Miriam. Please convey that, and thank you to you for the incredible work that you've done, and resources and capacity building, and really responding to what is really a critical and difficult situation. So I don't think we've seen the end. Yeah, okay. Yeah.
There's one more hand up from Jenny Nash.
Okay. I think that's the last one, and then we're going to, I think Miriam must be exhausted. So, Dr. Nash.
Good evening, colleagues. Thank you so much for a really fascinating.
Oh, it's Jenny.
Sort of an opportunity for healthcare workers to debrief. It's incredibly, incredibly.
I think you're breaking up.
Do you have any mechanisms for regular debriefing of healthcare workers, just looking after the mental health of your yourselves and your colleagues? Thanks.
Yes, absolutely. So after after expatriates do a mission, we always check in with the psychosocial unit. And when needed, we get help. And we talk about things. Everybody has a different way of dealing with this. We help the national staff by providing also psychosocial units. I will give you an example. Last year, I spent 7 months in Central Africa in an extremely poor area. Here I am in a wealthy place in comparison. And we actually brought a psychosocial unit into the country to start this to help our national staff, because MSF always works with national staff. We are a few people that come in. You might, I don't know if you would call us experts, but anyway, we come in from abroad to help. And then we work with the national staff to build capacity. Then our national staff works with MOH. We also advise them to set up similar systems to assist all staff with their mental health. You cannot be a caregiver if you do not take care of yourself, is my motto. And I have to say, I would like to add that I always find it a privilege to work in a country like Malawi and to be part of this intervention.
Thank you very much, Miriam. I think we need to draw this to a close and to really thank you for your superb presentation, for sharing these experiences, and most importantly, for the extraordinary work that is being done by your group, healthcare workers, and others in responding to this really dreadful crisis. We've seen the mortality rates go down. We've seen what has been put in place, and really our heartfelt thanks and admiration for what MSF and others have done. We need to brace ourselves for outbreaks in surrounding countries, and we need to learn these lessons and apply them. And cholera can be treated successfully, as you've highlighted. We cannot depend on the vaccine, but we need to learn the rules of cholera management and also prevention as much as can be possible in resource-limited areas. So thank you very much, and thanks very much, Theo and Right to Care, for hosting this, and all of you for attending. Thank you, Miriam.
Thank you so much for the opportunity. Good luck to all of you. Be prepared.
Yeah, absolutely.
Thank you very much, Miriam, and thank you very much, Professor Bloomberg, for facilitating this. I think this was a learning opportunity for all of us to build resilience in South Africa and the neighboring countries for a similar situation like this. Just to share with you that Miriam have contracted cholera herself while in a camp, refugee camp in Sudan. So she speaks from a practical experience in managing these cases. Miriam, thank you very, very much. Thank you very much, Professor Bloomberg. The recording of this presentation is available if you want to utilize that. And Miriam, we will placing your email in the chat so that if there are colleagues that want to communicate with Miriam, I'm putting her email in the chat and that you can also communicate to her. Thank you very much.
So thank you. There are local guidelines for managing cholera in the region. These are based on international best practices. You can access them on the NICD website, and you need to have them in place in your health facilities and prepare in advance. Thank you very much.
Thank you, Professor Bloomberg. Thank you, Miriam. Thank you, colleagues, for attending. Have a nice evening.
Thank you very much. Have a nice evening. Bye-bye. Thank you.